Hi, I'm Chris Sarkadoulis, and this is the second in a series of Soundbites online seminars that we've been doing during the COVID outbreak. This one is looking at the role of numeracy, the kind of math you really need to understand most of the COVID messaging. Hope you find it useful. At the end, there's a way you can contact me and a list of who I think were the participants today during the Zoom call. So thanks very much. Stay safe. Before we begin the numeracy discussion, our colleagues from New Zealand were actually implementing or trying to think through how something related to concepts could be incorporated into some of their work. So, Carla, you've been designated to talk to us a little bit about that.
Thanks, Chris. Good morning, everyone from here in sunny New Zealand.
One interruption. Can you all see Carla now? Because I have this square up on the screen.
Yes.
Okay, good. All right. Hi, Carla.
Hi. So we've been doing messaging for our Ministry of Health for people with disabilities in particular. And one of the things that we noticed, people were talking about the need for plain language, and so we as the health literacy people were trying to assist with that, but people were missing some of the key concepts out, and they were dumbing down messages. They weren't actually trying to make messages clearer, and so the concepts we noticed, one of the ones that was being missed out was they were talking about be careful what you touch, anything you touch can make you sick. So they were missing out the bit about mouth, nose and eyes. And so, you know, it gives people this false idea that it's absorbed through your skin.
Oh, wow.
You know, so just, they were trying to say avoid touching things, which is fine. But if you don't give the whole message about how transmission happens, you know, you give an entirely wrong impression. And look, the other one that we picked up, and this is just something we weren't writing about this specifically, but it reminded us to do this, and it was about the immunocompromised concept and how poorly it's being explained. Because and the assumption that people just know what immunocompromised means and whether they are or not. So we had an article in our NZ Doctor where they were trying to say you need to be careful because some patients have really low health literacy. And they talked about a patient who was recovering from cancer and had type 2 diabetes and had been identified as an essential worker. And just luckily his GP was talking to him, and she said, and he didn't realise, you know, I sort of saved his life because I explained to him that he was immunocompromised and he really needed to stay home, which he is doing. But it's not him having low health literacy. It's a series of poor explanations and a lack of advice that people have been given to build an understanding around what causes it, how it changes, what it means. So those are my couple of examples.
Those are great. I think what's fascinating about, I mean, you're hearkening back, whether you know it or not, to the first AMA video that ever was done on health literacy. It was called A Prescription to End Confusion. And they would interview patients who, you know, he didn't know what hypertension was. And, well, you know, does that mean I'm hyper? And the doctor turns around and says to him, well, I haven't been doing a good job explaining to you. They said it, but the whole field became, these people are low health literate. What's wrong with them? Rather than sticking with the, what about my messaging here? So, I think and not only that the immunocompromised, the term and the concept, in the last 30 years, it was at the surface with so many people during the original HIV AIDS outbreak. And that word was used a lot. It then, what happens with language, it got extinguished. We don't use it as much. And now, because of an infectious disease, it's up there again. And I agree with you completely. I think people do not have a good workable understanding of it. So if you actually do write any material around this, I hope you share it with us, because if I don't know how many of you are on the IHA discussion list, but Cindy Brock was already asking who has written low-level literacy material for COVID. And on Monday's talk, I'm going to look at some of that material, and you will find no concepts in it, no explanations, the why. Why should I not touch anything, as you say, Carla? It's just how cruel to just leave all of that critical information out. I mean, how dare we? Anyway, thank you for just keeping me thinking about this, because I'm trying to write something that has to do with what would maybe we should all do this together. What would be the new sneeze into your sleeve, wash your hands, and stay home? What would be a new, more sophisticated way to talk about basic hygiene, but also to advance the public's health literacy? So I put that out as a task, and I'll follow up, and even on my blog, because if we want to keep talking about things and maybe come up with developing something, I'm right in there. I just don't want to do it alone. I've decided 30 years ago, I'm not good at just doing things on my own, and my sleeping dog can verify that. All right, so let's jump into numeracy for a while. Interrupt at any time. I'm going to just tell you what I know about numeracy. I've been looking at it for, like everything else, for a very long time, well before it was incorporated into health literacy, because we always knew in reading and reading comprehension and linguistics that reading, writing, and working with numbers was fundamental literacy globally. That was the definition. And numbers got really waylaid in the field of health literacy. Also people in all the other sciences have talked about working with numbers in very different ways. The cognitivists who are working on how we process numbers versus the linguists, what's the language of numbers, versus the reading comprehension people. So it isn't sort of one field, it's a beautiful interdisciplinary field. So, and at the end of this, I actually leave you some references. So again, we've got this issue of, okay, we've got all of the language, we know it's chock full of things, but we're gonna focus on language because it is the Achilles heel of understanding most science and health information. And just as low as our literacy levels are, our fundamental literacy levels, that's how low our math abilities are. So again, we're unpacking COVID messages now, but we're looking at this skill of ours called numeracy. It's, we talk about it, our ability to identify, work with, and come to conclusions when it has to do with numbers. So in numeracy, we talk about basic numeracy. Can you identify numbers? When you're scanning a page, can you see the difference between letters and numbers? It can be as basic as that. Computational is everything beyond identifying numbers, and I'll give you some examples. Can you manipulate numbers? Can you balance a checkbook? Can you tell the difference between 150 have died versus 100? Do you know that's 50 more in the other, let's say, geographic area? The third category is analyzing, which is, can you make inferences from numbers? Can you do estimates and proportions? Very, very important. And the last one is the statistical skills that we bring. I have none of them. That's why I did qualitative research, but the statistical, the knowing probabilities, risk. And so we will see that with COVID, they're all in play. In the field of health literacy, as I said, the vast majority of work that's been done in numeracy was done in the 80s and 90s, and it was all about patients who couldn't understand their prescription labels or their directions. Take 2 tablets by mouth twice daily. And there must be, if there are not 80 to 100 studies looking at how bad patients are with prescription labels, then I'm really at fault. But that's really been the focus. A lot of the interplay between simple language and numbers around prescriptions. So it was prescription labels. Then at about 2000, as electronic medical records were beginning to come into play, and people did have to look at lab test results that they received electronically. There was an interest in health information that was a little more sophisticated and complicated than a prescription label. And I have a video example I want to show you of that. And only in the last, say the last decade, the work in visual representation, which has been alive and well for 20 years. I don't know if any of you know Tufte's work on visual representation. I mean, people have been working on visual representations of numbers for a very long time, but it's just beginning to percolate into the health field, the health literacy field, with people like Jessica Anker at NYU, and I'll be referring to her again. Okay, so numeracy, the way I approach it, is its own language. You have words and numbers and the translation between words and numbers, and the fact that both those words and those numbers are representing things. But these are simple systems. I mean, math formulas have a grammar, and we'll look at how remote that can be for most people. Just the idea that people with poor probability reasoning had a hard time just even deciding, in 10, in 100 versus 10%. That is a confusing grammar to a vast majority of people. And, the proof is there, the data is there, the studies are there. And I just left a few in here as examples. Poor numeracy abounds. I mean, I think I've talked a bit about, our low science literacy around science concepts. Well, we're not a hell of a lot better with math. We can have some very situational skill in math. For example, I, as a New Yorker, can read these very complicated no parking signs. I don't know if you've ever seen them. No parking between 3 and 7 and 4 and 2, except Saturdays and Sundays, because I have the context, the need, and over again, I've had to ask people, can I park here now? So we can do some really amazing things with numbers, but it's often very context dependent. So simple things like, and now why I like these studies is that these were highly educated people. And in this case, oh no, it's not the women's study. Only 32% of people got the question right when we gave them the answer. 16 to 20%, oh no, when we said which represents the larger risk, 1%, 5%, or 10%, the vast majority of highly educated people couldn't figure out which was the larger number. And I'll give you another example. Have any of you used the new vital signs? Yeah, I don't know why it's muted. You should all be unmuted.
I've used it. I couldn't, my students, college grad students weren't able to pass it very well.
Yeah, I mean, I've done, when I used to subject people to the humiliation of taking some of these literacy tests, I've had whole classrooms of my college students in public health not able to figure it out. So the idea that numbers are remote from most people is widely accepted. But I want to focus on this notion of it's not just low income, low literate people. Schwartz and Walsh, and they've done a lot of studies in literacy. I think I have them listed at the end. They took a group of educated women, and I believe they all had, they didn't have breast cancer, they had all had a mammography. And they found that a tiny percentage, 16% of the women, they asked them 3 questions that had to do with their risk of recurrence of whatever was on their mammogram. And what they found is that the 3 basic questions about risk and mammography were the vast majority of people couldn't understand them.
Yeah.
And
Okay.
And then I just put 2 others, the classic studies that were done. This one is about absolute risk reduction. Also, again, people couldn't even tell if a treatment option has more benefit to them or not, when we're always offered different treatment options in terms of which would have more efficaciousness. Look at the numbers. You know, participants correctly identified which of 2 treatments would benefit them less than 0.5% of the time. Again, these were not low health literate people. And in a jury study, which is another fascinating study to read, less than 1/3 could identify when they were looking at a survival curve. Less than 1/3 of these people could identify, calculate, you know, the difference in survival curves. So again, lots of evidence, it abounds, but I always use something like this because I'm pretty math illiterate. Imagine that you flip a fair coin 1,000 times. What is your best guess about how many times the coin would come up heads in 1,000 flips? Does anybody have a clue? Well, the answer is 500, but that's because I showed it to you. So the thing is, in simple word problems, and I'll leave these up for you, we're not going to go through them now. I mean, I fail abysmally, but most people struggle. And, you know, these are not consequential. So let's look at some consequential stuff. One of the first things I started to do when I was thinking about the material that people were most going to look at right away with COVID was hand sanitizer, right? So I went to the CDC site. I had to really work at it to find out if I wanted to buy sanitizer or make sanitizer, what did it have to contain? So when you talk about the basic level of numeracy, that means somebody can say, oh, this is a number attached to the ingredient of alcohol, and it's 80% of something. Okay, you're not quite sure you understand what 80% is, right? Then you get to a label. This is a Purell label, right? And through all of this, right, you've got to find the number that's relevant. Now, if you remember correctly, this says alcohol, ethanol. This says ethyl alcohol. So, you know, linguistically, it's not an exact match. But if I'm fairly perceptive, I can say, okay, that's the ingredient. This is 70%. Well, is that good enough? Okay, and here's one more. This was interesting to me because I'm always looking at organic products. You know, this one had a hint of lavender, as they would say. And what happens with this label? Well, you have to find the number related to ethyl alcohol. It's organic, so that's probably good. I didn't know they could have organic ethyl alcohol, but let's say they can. What about this? So the basic level is you find the number. The next level of numeracy skills, as we said before, is what? Can you work with them? So can you tell that if it was supposed to be 80% and this label is showing 62%, that this doesn't have enough alcohol in it? That's what computational numeracy skill is at the simplest level. So let's assume 1/3 of the population can't do this. So even this alone, this basic number skill, has consequences right away. One more example of calculational, the second level of basic numeracy, when an expert says that the infection rate is doubling, you have to know how to double things, how to multiply them by 2. Again, it's constant. We are immersed in this numbers game stuff, but you have a sense, does everybody have a sense about the basic identifying and computational levels? Okay. And I can't see you all for some reason, so I just want to make sure you can jump in. Is this all unmuted? Yeah, everybody.
We want it to be. Yeah.
Everybody, I want it to be. Can everybody unmute if they have something?
Well, a lot of us, we mute because then you get an echo if everybody
okay.
unmutes at times.
So can I trust you to unmute yourself if you have something you want to put? Okay. So
Certainly.
Okay, so you get the basic 2 levels. Now let's look at what really is at stake here. This is how I see it. We talk about, I said to you before, well, math has its own language, its own grammar. So math represents something. It stands for something. We see words. Sometimes, people say, well, why don't you just explain to me without the numbers? I get a lot of that in focus groups when we're talking about risk. And you can say, well, that's very risky, or that's somewhat risky, or that's more risky than this. And people sort of, okay, they like that. But then when you ask them, well, what does very risky mean to you? It's vague. So people feel affectively good about just taking away the numbers and using words, but then they are left unsatisfied when they have to judge what that really means for their own actions. So we're in a bind there. And in the same token, if Dr. Burks was to stand up and not have any charts or numbers behind her, it's not as credible. So people are very conflicted about numbers. We have been for a very long time in life. But we know other things. We know from the research that how you work with certain kinds of numbers, say percentages versus proportions and pictures. There's a lot of good research in fields unrelated to health, out of the field of health literacy that I just want to introduce you to if you're not already. And the fact that through lots of usability studies, which is the kind of work Jessica does, I do, when you're actually bringing people into the lab and putting them in front of your brand new electronic medical record and asking them to use it, what happens when they're trying to work with numbers. So I want to show you an example of this. We had an NIH grant to look at just how people were going to understand first, did they want to log on to the patient portal if it was accessible to them and free? And then how on earth were they going to understand lots of the information? And today I'm only going to talk about one type of number representation, and this was a simple chart. Now, this is a cholesterol chart right from one of our samples. And what I'm about to show you is how one of our participants during our usability study actually tried to interpret her cholesterol numbers. So these numbers down here. I don't think my link, oh, here it is. Let's see if this works. Of course. I'm going to just enlarge it for you. I think we use a system, very common one, Moray, where Wendy is beside the woman in this case, and I'm in the other room watching, and everywhere that her pointer goes is where her...
Stop sharing. Yeah.
That's better?
Good. Yeah.
You can see
Thank
that?
you.
Okay. Wendy, interrupt at any time. And this woman has just been asked with this fictitious patient in this medical record, tell us what her cholesterol numbers mean. Wendy, was that the kickoff question? Wendy's there.
Yes.
Okay, so let's hear it.
Let's look at that first one that you said, that cholesterol panel, that first test. Let's get more information about that one.
All right. All right, says status, edit.
Okay. So now, what are Mercedes numbers for cholesterol? Oh, that's okay. Just click out. Yeah, there you go. Oh,
We found a lot of people who just
All right,
took themselves
okay.
out
You
of the
can
whole
actually
system.
Go back.
Go back.
Let me see.
And these were earlier
So just click
systems
back
that
on
had
this
been hopefully somewhat made more user-friendly.
Okay, there we
There you
go.
go.
All right. So now, what are Mercedes numbers for cholesterol?
All right, cholesterol is 240.
Okay.
All right, standard range from 199.
So according to this patient portal, are Mercedes numbers normal or not normal?
We'll find out. View history results, general information.
So first, I want to make sure you caught that. Wendy's asking, okay, from those numbers that you just read to me, are Mercedes numbers, her cholesterol numbers, within a normal range or not?
Go to status. This is status edit here.
Okay. So is this page, and it might not be on here, is this page telling Mercedes? what
No,
are the
it's not
numbers?
telling anything. It's making her afraid of the numbers
Okay.
because she don't know whether it's good. You know, she don't know if she's been following it good or what she's doing wrong. The only thing it shows collected, the results came back on such and such a day. Result status, and it's just an edit, and that's all just information to the doctors, but not to her.
Okay, so you...
Okay. Now, this is not so unusual. What's going on here? So I have to go back to the stop. Screen share is stopped. I have to go back to this. So what's happening here with this user and this math grammar?
She's reading it just fine, but she can't understand what that means. What is the standard range with the value?
Right.
She can't infer.
Yeah, I mean, she's reading all the words just beautiful, right? So you have both, a fluent reader who may lack the math concepts, but what she certainly doesn't have is this grammatical structure here. That 100, she reads cholesterol 199 through or to 199, but this whole notion that from 100, 101, 102, 103 to 199 is a sentence. It's a very long sentence. And she doesn't have the facility of that. And I just keep her in mind because imagine what it's like right now, trying to listen to anybody who's talking about COVID statistics. Does anybody else want to comment on what else might, I mean, we can criticize the chart itself, but I mean, in terms of trying to figure out what the patient isn't getting about it.
Christine, it's Susan here. So sometime, I remember one person we worked with, and we were looking at their EGFR rather than their cholesterol, and they thought that they were doing really well because their EGFR was low.
Yes. Oh,
you know,
yeah.
And I can imagine the opposite here. Someone's looking at their cholesterol and seeing it's high and thinking that's fantastic. You know, I'm doing really well.
And you'll see this a lot. We're going to go to one other example where that is very alive and well. So, again, the language of math. You know, if you want to look at was CNN. If you want to look at these numbers, case numbers, COVID by state. So let's say you have 92,000 odd cases, then it says 477 per 100,000. These are the deaths per 100,000. All of this is the grammar of math. Then you see carrots like this, which are specific icons of the language of math. So if people just wanted to find out, and I know I have neighbors who are trying to find out how many coronavirus deaths we have in South Florida, they're looking at numbers that are also being presented per. It's lost on them completely. I want to get to the example that, go ahead.
Can I just add, I thought it was really interesting how little time the mouse, when you were asking about the numbers, how little time the mouse actually spent anywhere near the numbers. It was looking for clues in the words, because that's obviously where she felt really comfortable, but just avoiding that whole space.
That's a very, you know, we've shown this video and others like it a lot, and that is the first time someone's made that observation, and I think it's an excellent one. Just the proportionate amount of time that she lingers on the words refers to the words, but really doesn't go back to the numbers. That's a very interesting one. Yeah, why would we if we have a try? You know, it's like me reading a map. And I do a lot of studies about map reading. I am lost on a map, you know? So, you know, I'll talk a lot about, you know, other parts of it, the legend and everything, but not finding my way around. Okay, so the thing that kicked me off this time is the flatten the curve. So let's see just how that language shows up. Oh, I have to stop again. Stop sharing. Do I say new share?
One of the great challenges in this world.
Wait. What did you ask me to do?
You can stop sharing this screen.
Yeah, but
why hasn't
it shown up? For some reason, share, stop sharing. Okay, now where is the other screen?
If it's open on your desktop, it'll be one of the, if you say share screen, it'll be one of the pictures that appears on your desktop.
What do I do without you, Tess? I mean, this, and I love the background. Okay, let's pull this up, and I think this is going to be just an ad. But
is knowing enough about a subject to think you're right.
Okay.
I think you know from that large blue mountain that you can see behind me, and I just want to thank the 5 or 6 international and domestic modelers from Harvard, from Columbia, from Northeastern, from Imperial, who helped us tremendously. It was their models that created the ability to see what these mitigations could do, how steeply they could depress the curve from that giant blue mountain down to that more stippled area. In their estimates, they had between 1.5 million and 2.2 million people in the United States succumbing to this virus without mitigation. Yet through their detailed studies and showing us what social distancing would do, what would happen if people stayed home, what would happen if people were careful every day to wash their hands and worry about touching their faces, that what an extraordinary thing this could be if every American followed these. And it takes us to that stippled mountain that's much lower, a hill actually, down to 100 to 200,000 deaths, which is still way too much. Next slide, please. Simultaneously, there was a modeler out of the University of Washington that modeled from cases up, utilizing the experience around the globe to really understand how this information that we have from Italy and Spain and South Korea and China could really help us give insight into the hospital needs, the ventilator needs, and really the number of people who potentially could succumb to this illness. It is this model that we are looking at now that provides us the most detail of the time course that is possible. But this model assumes full mitigation. Yeah. It's informed every morning or every night by the reality on the ground coming from New York, New Jersey, and around the United States.
Okay.
And it's modeled and informed every morning so that it is adjusted so it is up to date.
I think you get the point of what I'm going to get out of this.
This is the model of the predictor.
Okay. So I'm going to go back to this. So, anybody want to venture? And oops, somebody needs to go on mute. We hear a little guy.
No, I have to go to camp on the live call.
Okay.
It's whoever phone ends in 8517.
Whoever has
You need to turn on your mute.
Can you turn on your mute?
Sorry.
That's okay. So, given Dr. Birx's given Dr. Birx and many other people who are talking about flatten the curve on all networks, CNN and Fox, how do we unpack that is my question. I took a stab at some of it, but I would really love your input here because you have to know that somehow you can track numbers, you can count people, you can track what, sort of numbers of people who get sick, and you can track them over time. You can track how fast, which means you have to know something about what rate means. You can track them geographically or the severity of the illness, on and on and on. There is surveillance and collection of numbers. Now, you can explain that to people, and people know that because they save money, they keep checkbooks, and there's an innate skill that we bring to some of these concepts. And then there is, the numbers can be represented in a graph. And that's what that mountain and hill is. It's a graph. But beyond that, what underlying concepts and math do you need? And I've been trying to think this through now for 2 weeks. And I don't know if I'm there yet. I don't know how to explain to someone why that littler curve is what we want.
Well, it's all about that dotted line about hospital capacity. And in half of the stuff I've seen, they don't even stress that, because it's only when the curve goes above hospital capacity that then we have a lot of extra deaths, because we can't put people on ventilators and ICU units like we need to. And so I think it's even more challenging because this is a multi-dimensional graphic here.
All right.
It's not just about the surveillance. It's also about how well that overwhelms, because bending the curve is all about flattening it so it doesn't overwhelm our capacity.
Okay, this is what, Stan, I agree with you on this. And what I found is that the major story that people aren't getting is that people get sick, across the line. If they start getting sick very fast, in large numbers, and tell me if I'm wrong on this one, the curve goes up, and that's where capacity becomes a problem, because if it is like on the faucet that I think Cuomo or somebody used, if I turn the faucet way open, lots more water comes out, lots more people are sick and they need the hospital, right? And that's the curve going up. Am I right or wrong about that?
To me, that's what it's all about, because you know, if we bend the curve and we have capacity, then less people will die. Once we go over capacity, then we'll have to start implementing those policies of who gets ventilators or not, and the people who don't will die. And so to me, it's all about that.
So what, when they say flatten the curve, lower the curve, they're really talking about rate and capacity, right?
Yes.
Okay.
Correct.
I think so.
All right.
Well, also people on ventilators can still die. I mean, people can still get treatment and still die,
Right.
which also isn't represented by that graphic.
Well, and I think this is Wendy. The other issue is that it doesn't mean that people are going to stop dying. It's going to happen. It's just going to happen more slowly when you flatten the curve. The real issue is, I'm sorry, as the person who was speaking a little earlier was saying, the biggest issue is hospital capacity.
Okay. All right. Can you talk to?
I know that. I just don't think that it doesn't. I mean, as we're talking so thoroughly about this graphic, the graphic is, you know, I think we're realizing how, as people said earlier, how complex it is, and that you have to take an extra step as well to understand both the rate, the capacity, and then also that people are going to die anyway. It just, you know, the treatment is still, you know, this virus is still strong enough that it can resist all intervention. So the multiple things people have to understand to be able to even understand that graphic.
But then, do you is it that when the curve is flattened, more flat, you still have mortality, but you have less of it?
You have less at any one time.
Right.
So the same number of people would get sick, but like that garden hose, we want it to come out more slowly so that it doesn't flood the garden all at once.
Okay, so it really is, as Dan says, about capacity.
Well, I've seen one good graphic, Chris. You want me to? Let me share my screen for just a second.
How do I do that?
Because this is one. I think. Let me see.
Do I stop?
Oh, you'll have to stop sharing, and then I think I can share.
I'll stop share.
Okay, let me see if I can, because we've been using this on our website, and I think it's been the most useful for at least that I've seen. I don't know if you've seen this one.
Who don't know, Stan is Wisconsin Health Literacy, and I have a reference to him at the end. All right, so let me see that again.
Can you see that?
Yeah.
Does everybody see that?
Healthcare system capacity.
So it even puts it in a little cartoon way too, so you can kind of.
Whatever, it's just like a colder. Oh, I see.
But it really stresses that capacity, because that's what it's all about.
Can I just say, Susie Wiles down the bottom, she's a Kiwi.
There you go. We stole it from the best.
Oh, you're kidding. Go ahead.
There's an interesting aside to that, though, because it means that the message we're giving is that the same number of people could still get sick, but the problem is that if we all get sick at the same time, there are unnecessary deaths, not from the virus, but because our system can't cope.
Yeah.
Yes, exactly.
But here's where I lose the argument. Because then everybody, all the experts, as they talk about this, talk about the curve will flatten if we're doing good mitigation, practicing social distancing. So the formula is not just, there's another factor working on the lowering of the curve, and that is human behavior. And I can't figure out how to show that.
Well, I think there's also confusion about what quarantine is and what isolation means. I mean, we're really not practicing quarantine. It's not a true quarantine, and we're not isolating cases because we're not able to test enough cases. So we're trapping folks with people who might be sick. So we're really not stopping people getting infected. We're just slowing it. Right.
But now, Wendy, more and more in the last 2 days, you know, they're slapping our hands for not doing proper mitigation. And you know, they're going to start explaining more about, you know, hammering away what mitigation is. but how would you show if lower means it's the rate and capacity, but rate is also influenced by, I mean, I'm sorry to get so technical or so literate here, but I'm trying, if the rate is influenced by human behavior.
And then that's influenced by policy, because
Right.
there are still a lot of states that don't have a shelter in place.
Excellent. That's the kind of formula that the story, and I don't mean formula, this is the story I want to tell, because nobody's telling it.
No, I think it'd be really interesting to look at I don't know, I'm a sociologist and I haven't really studied this area, but the compliance rate, because what I'm seeing here in Wisconsin is, there are a lot of German Methodists who really listen to the government and obey it. And so there's a lot of compliance. And I'm wondering, in a place like this with that kind of culture, is there going to be less spread? Are we going to bend the curve better than, say, my home state in Missouri, where the governor is relying on people's personal responsibility to keep them inside their houses?
Oh, I think it's just, that's the fascinating part of this. I was talking to somebody, was I telling you about my German friends? German Americans living here in America. And they are just so frustrated with Americans who don't listen. Everybody in Germany, you listen, you do what you're told. And they just are so, I mean, they're furious with Americans. We're contrary, we're libertarians, and you are going to see enormous cultural differences in how.
So just to, I have to go for a call at 5, but I also think, well, I'm going to go, but not to stop us talking. But there are certain people, so people who are in healthcare, or people who are performing essential job functions, who are doing deliveries, who are all being exposed, but we don't have enough testing capacity to know who's infected. Right. And then people are going back home and then making their families sick. So there's a social component to it that, people's behavior is also not going to be able to take care of if we don't. I'm just making my I'm waving my thing about testing being really important. And I'm personally sensitized to this because my husband is exposed at work, but he can't get tested because he's not symptomatic. So we don't know. He could be coming home and infecting the entire building, and we don't know.
Building. And you can imagine what happens when people are supposedly sent back to work. I mean, this is why I think this story of flattening the curve becomes so essential. Wendy, I know you have to go. I'm so thankful you were on. I'm just going to breeze through the last 3 points. And Wendy, dear, would be really great if you could make some contribution to the blog so we can keep this going.
Yeah. I had my students, supposedly they were going on during their midterm. I haven't had a chance to check it yet, but I'm going to see what they may or may not have posted. But it was a pleasure joining. Really fascinating conversation, and I'm going to hop off now.
All right, stay safe. So just to close on here, because I know, as my ex-husband said, I have a problem for every solution. I don't want to just end with problems. Is that we do know a lot about how people react to numbers, and some of the stuff you probably know as well. As I was saying before, the words, people feel affectively, emotionally better, but they also agree that they're vague. We can't just say a lot of people are dying in Miami. It's just, and we can't say more people in Miami than in Palm Beach. But there are things we do know. We know percentages. People have a very tough time with percentages, and they do a little better when it's a proportion. And I'll show you just an example of this. We know from tons of work done in genetic counseling over the last 2 decades that frequency of something, if you can show people how frequently people are getting sick or how frequently something happens, that is much easier, especially when you're talking about risk. Now, I don't know if it was Carla who brought this up before, but this whole idea of have you heard of denominator neglect and denominator confusion? Right. This whole idea that if you'd say, 7 out of 20,000, or you know, 4 out of 20,000. People can't, they confuse the numbers and think, oh, is 4 in 20,000 versus 1 in 20,000, which one's clearer? And it's this problem here because they actually are focusing on the denominator often and not working with the critical number. So people are pretty well settled on the fact that if you're going to have to use numbers like this with denominators, come up with better ways to visualize. And, you know, this is Wang's work, and Jessica Anker has worked on these. The idea of certain chunks of people out of others is one way to do it. I thought Jessica's recent work, it's in a video I've included a link to here and in the bibliography. There was, at one point, this tested like, well, how many people is that? You know, what proportion is that? And this tested better because you could see sort of like, oh, okay, it's like that many people out of everybody. But this kind of graphic was very much better than this at conveying the concept of randomness. And a matter of fact, Jessica did an intriguing study where she had this all yellow, and she asked people to just keep clicking until the blues came up, and she thought that would give them an idea of randomness. But what happened is they got so anxious every time they clicked. But the point is powerful, powerful effects of the ways things are visualized. Stan sent me this, and I just love the idea that you can use things in people's lives, in their contexts or in their relatable contexts, to show numbers. And I think we have to figure out a way with something more complicated like this rates and the hospital availability to do things that we know work for people. Go ahead.
Christina, interestingly, in the work we're doing with disabled peoples, they have said don't use social distancing because they want to be socially connected. So we've definitely gone for physical distancing.
Physical distancing.
Yeah, and using things like when you go to the supermarket, you have to be 2 supermarket trolleys away from the person in front of you.
Yep.
You know, it's taking that term, which is a public health term, social distancing, is a worst term.
It is. It's so bad.
It's so bad. It's just like, it says everything wrong about what we're trying to do. Like you say, people want to stay connected, but you can't be physically connected. I mean, it's just that, you know, but that's what happens with language. All right, I'm just going to leave you with these thoughts that relying on usability studies or even your own informal usability is the best way to determine if we're getting closer with ideas for communicating these things. There are a lot of icons that have been tested culturally for acceptability out there, and sometimes I call upon them, especially if I don't have the time to test things. We know that when you can also give people an app or an easy to use tool, they're so much better off rather than struggling with the numbers themselves. And I think what's happened in COVID is the numbers have become so dizzying. I mean, we know people once the numbers get very large, million and billion, people really can't even process it. So a way to engage people in the discussion of numbers, I think, is also not happening at any level. I'm still going to go away thinking about how to talk about rate, and because as everybody on this call has said, rate seems to be fundamental in understanding what is going to happen if we don't practice better public health behaviors individually. The system is going to be overwhelmed, and many people are going to die. Look, if they stop letting heart attack patients in EMS ambulances get delivered to the hospital because the rate of COVID illness into the hospital is so high, it has real implications for people. I'm going to just leave you with this. Talking about numbers in terms of analogies is good. The spigot, and in this case, it was the subway car that I thought was really good for New York. If you think of us all rushing onto a subway car together. So, you know, the tried and true ways of talking about things. I have yet seen anybody talk about statistical modeling in a way that makes sense to anybody. Has anybody seen anything that, I mean, I barely know what statistical modeling is, but you know, everybody's referring to it. Well, the model says this, the model says that. And I was wondering, I was talking to a good friend at the USGS, the US Geological Survey. We've done a lot of tsunami work together. And I said, you know, I'm wondering if people could relate to hurricane models, you know, with the cone of the hurricane. And I know in the United States on the East Coast where we get hurricanes, that is very familiar. People do know you have a model that shows it's going to hit New Orleans and a model that shows you it's going to hit Virginia. Anybody else see anything, any good conversations, good ways to communicate what these models are showing about COVID? Because, you know, you need to know something about, it's just, the model is just as good as the stuff you put in it to begin with, is the working assumptions you put into it. And those assumptions and numbers change, the models change. You know, that's another one I'm going to be thinking about this week. And one I just put out there, it's so sophisticated a concept, I barely understand it. It's the idea that, again, this is vital to social distancing, is that we can all practice social distancing, let's say here, exactly in the town, the city I am in now. We can really be rigorous about it. We are not necessarily going to see any numbers drop or change for quite a while. And social behavior around this, which they found during the pandemic of 1917, is people say, what the hell is this? We've been locked up for 3 weeks and the numbers here aren't coming down. So that lagging indicator, which is what it's called, is totally alien to people. And then we run the risk of, because they don't have this concept in some very, you know, that's a basic way. The way I understand it is a pretty basic way. Why not talk to them about this and show them that even if we, you know, we're going to start practicing this now, don't look by Friday to see changes in mortality rates here. So my mantra you've heard before, I don't need to waste your time with it again, but I don't want to go over an hour. You'll never speak to me again if I continue to do this. How can I, is there anything I can be thinking about, or anything you want to suggest or share? I'm very serious about, you know, my blog is a lonely place. I have a lot of people who look at it every day, but nobody seems to put out ideas. You know, I had 500 people look at it yesterday, but not anybody suggesting something. So you are my chosen few. I'm asking you to post things. All you have to do is say, hey, Chris, I want to post this visual, or I want to post, I'll put it right up for you. Because I do believe a small group of people can change this dialogue. And on Monday, I'm going to show you what the feds and what some states are putting out there right now that is more of the simple stupid. And it's going to win over the day because nothing else is suggested.
Chris, I don't know if this is happening anywhere else, but in New Zealand, there's a concept of staying in your bubble instead of stay at home. So you have a bubble.
Huh.
So I'll put a link on your blog to Susie Wiles talking about bubbles. Susie Wiles is the scientist who did the flatten the curve thing that Stan showed. So I'll put a link to her work. She did some work about showing bubbles and how you can break your bubble.
Does she work on communicating science?
Yes, that's one of the things she does. She's got bright pink hair.
And what's her name?
Susie, but it's spelt like the Sioux Nation with S-I-E at the end, Wiles, W-I-L-E-S.
Excellent. Excellent. Anybody else right now?
I think we need more what in public health we call social math examples.
Right.
So I heard a good one the other day. Someone said Florida is going to get hit with a hurricane that's going to stay for 30 days. And that's your hurricane example that people can understand. It'd be nice to know if it was a category 3, 4, or 5.
Well, that's a good one, because we have been talking about it. Well, it's like a hurricane, but it's not. My neighbors will say that.
Yeah, but it will be the impact, the number of people who die from it. I think people are having a hard time with the concept of testing versus fatality. They think that the rising rates of positive cases means something, but it mostly means the state has capacity to test, not what's really happening. And the other concept that hit me over the head was somebody was looking at this mountain curve and said a lot of people don't realize that just because we get to the peak at a certain point, we don't go down much the next day. It's just one case less than the day before, and that happens for a while. So this idea that you're talking about of lagging indicators, I think people do need to be prepared for what's going to happen over the long run. The idea that as many people may get sick, but maybe, my question for myself was, do I go out and get myself infected right away so I could hit the hospital system while it can handle me? Or do I wait for 6 months when maybe they've got a better sense of how to deal with the novel virus?
Well,
so I think
that's a very rational way to think about it.
It's like, do you expose your kids to chickenpox or not? I think we need to prepare people for the long haul. I think any word examples we can come up with, like hurricane for a month, might be helpful.
Well, and even the longer haul too, because we got to remember the pandemic was 3 waves. It was not just a single wave. And if we all do good social distancing, then that means about 95% of us will not have any exposure to this coronavirus, and it'll still be novel. And so I think, we've got to remember that and keep that in mind. This is just not one passing wave.
Yeah. And that gets back to why I think the history story is always so important in science. What we learned before, we know something about the waves of these things. Well, all right. And I can't thank you enough. I really am very serious. I just would like us to make something happen if we can. So any ideas and all ideas are welcome. Okay.
Thank you for this chance to talk together.
Stay safe.
Thank you.
Everyone have a good weekend. Stay safe.
All right, have a good weekend. Stay safe.